Hello everybody, I hope that you're okay. You will all be joining us at various times, but just to let you know, this is the start of the Menopause Webinar for this evening. And hi Flora, I would like to welcome you all and thank you so much for all coming back after the technical glitches I had last week. It's lovely that you've all messaged to say that, you know, when's it going to happen? So that's fantastic. So first of all, I would like to welcome our special guest, Tony Parsons. Welcome, Tony.
Thank you. Thank you, Victoria. It's kind of you to ask me to join you.
And it's very kind of you to come back after last week. Okay, so what we're going to do, please use the chat function box to chat amongst yourselves. If you have any particular questions that you would like to ask Tony, if you can please put that in the Q&A box. That way I will be moderating that. So when Tony's talking, I will be looking to see any questions that are coming in. Okay. Right. So we're going to be talking about surgical and medical menopause, and we're also going to be talking about breast cancer, the menopause and HRT. Okay, so I will hand it over to Tony to talk about surgical and medical menopause in a nutshell, and then we're going to be going through some of your questions. So over to you, Tony. Thank you.
Thanks very much. Yes, I thought it might be useful to just spend a minute at the beginning talking about some of the terms that we use in menopause, because it often causes quite a lot of confusion. See, to healthcare professionals, strictly speaking, the menopause is the time when you have your last period. It's not actually very useful because, as I'm sure many of you know only too well, you can get menopause problems before the periods stop. You can get menopause problems after the periods stop. You can even be unlucky enough to have both. It's not even that it's telling you that you aren't fertile any longer, because it's not a reliable marker for that. So although it tells us something's going on, it can be misleading, and we often see people who are told they're post-menopausal, and to us that just means it's a year or so since their last period. But to most people that would mean, oh right, so it's over, so no more trouble then. And unfortunately that's a bit on the optimistic side for a lot of people. So I thought it just worth getting those terms straight at the beginning. And then we've, as Victoria was saying, we've got natural menopause typically happening average 51, 52, but a really big spread. So 5% of people stopping but by mid-40s, 5% going on to mid-50s. Then we've got surgical menopause, which we're going to come and talk a bit more about in a minute. And then lastly, medical menopause, where medical treatments, particularly radiotherapy or chemotherapy, can actually cause the ovaries to stop working. So that's the kind of background structure we're working against.
Yeah, absolutely. Okay, thank you for that, Tony. Right, we've got a question in the question box already. I will look at that when Tony is answering this first question. Okay, so these questions initially are surgically related questions. Okay, so we've got somebody in their early 40s, had a hysterectomy 3 years ago due to fibroids. Her ovaries are intact. Now, the patient says she hasn't had any follow-up surgery, since the surgery. And she says, I have no idea if my ovaries work. I was told that my ovaries may stop functioning immediately or within a couple of years. I have no idea if the symptoms I have are linked to menopause. And the symptoms that this lady is reporting is brain fog, headaches, difficulty sleeping, cold sweats at night, and anxiety.
Okay, well, this again illustrates the problems we've got with the term menopause. Some people, when they have a hysterectomy, have their ovaries removed at the same time. And obviously, they go straight into a lack of estrogen and potentially getting symptoms. People keep their ovaries at surgery. It's really quite variable. If you lump them all together, if you'll pardon the expression, then their menopause on average comes about 18 months earlier than it would have done otherwise. But when you look at that group in more detail, you see that there's a subgroup where the ovaries really give up quite quickly. So say very roughly 25% ovaries giving up within a couple of 2 or 3 years of the operation. But you're right, if you haven't got your periods, you haven't got the marker any longer. And what I usually say to people who haven't got any symptoms is to try and ask for a blood test about every 3 years or so. The logic of that is that if you don't have any menopausal symptoms, nonetheless, you may still want to think about protecting your bones and your heart. So you need to know when you become menopausal. So that's what I often suggest for people who aren't getting symptoms. For people who are getting symptoms, and I suppose we ought to say a word or two about blood tests. Everybody would like a nice blood test to show that they're menopausal. Sadly, the blood tests usually are not helpful. They can sometimes confirm that the ovaries aren't working, but they can never really tell you that they are. So it's one of these rather unhelpful tests where if it's so-called positive, you've learnt a bit, but if it's negative, you haven't learnt anything. And unfortunately, we do see a lot of ladies who are told, oh, the blood test's an FSH, your FSH is normal, so you can't be menopausal. Not so. So what we usually recommend actually is that you usually base these judgments on the pattern of symptoms. That can be a bit tricky because there's an enormous range of symptoms that can happen at the menopause. But having said that, there are some things that are commoner than others. So I might want to look in a bit more detail if somebody came up with something kind of rare that we occasionally saw at the menopause. But the list you've just given is classical, really. My guess is the blood test isn't actually going to be that helpful. Those are all things which would respond to the right amount of estrogen. And we can talk about that in a bit more detail later on. But perhaps at this point, it's worth saying, because I'm sure people are going to say, yeah, but what can I take if I don't take HRT? Most of the evidence about HRT, and we've reviewed this sort of nationally through the NICE organization about 5 years ago, most of the evidence about things other than HRT only tells you whether they deal with the flushes and sweats. And because estrogen's got so many different effects in the body, you don't really know for sure. Sorry, I'm just slightly distracted by a door. It's a cat, sorry. Yeah, so because estrogen can cause so many different effects, estrogen tends to be the only thing that actually, replacement of the estrogen tends to be the only thing that will deal with a whole range of symptoms. So we could suggest all sorts of things that might help your flushes and sweats, but they're not going to help your brain fog or your joint aches and pains or various other symptoms. So yeah, in summary, I'd say that sounds classically like those ovaries are giving up. They don't always give up suddenly, of course. Sometimes it's a little bit of a roller coaster. So you might have, if you didn't do anything, you might have those symptoms for a few months and then find they got better and then find they came back again, because the body will always, as long as the ovaries are there, the body will always try and get a bit of work out of them. And if they seem to be underworking, then it'll crack the whip and you may find you get a little bit more estrogen for a while. So these symptoms can come and go, but they sound classically menopausal symptoms.
Thank you, Tony. So we have got some questions coming through, which I will write down when you're talking, because we've got a few now. So the second question that we have, somebody had hysterectomy for endometriosis under the age of 40, been experiencing menopause problems. They are progesterone sensitive, and they find the side effects of progesterone affects mental health. There is the risk of endometriosis recurring. Menopausal symptoms including change in odour of vulval area. That's all the person has said here. So no other symptoms recorded, but I'm sure that they do have other symptoms. Okay,
so yes, so surgical treatment or hysterectomy for endometriosis is relatively common. I have to say that as a profession, we don't do desperately well with endometriosis. And for those who are interested, there's quite a there's an all-party parliamentary group that have been looking at endometriosis for a while, and they brought out a report only a few weeks ago, really just saying that we're not doing very well. We're a bit slow to recognize it and diagnose it. And although we do have some specialist centres for dealing with it, it's often dealt with by general gynecologists, really.
Mm-hmm.
So the issue, of course, is that endometriosis tends to feed on estrogen. So if after the hysterectomy, you have no estrogen there, so let's say if they remove your ovaries at the same time, then it's very reasonable to expect any remaining symptoms to go away. It's tricky. The surgeon can often make a comment on whether she's removed all the endometriosis or not. But even if she has, the problem is that the endometriosis can often cause some scarring. So some abdominal pelvic discomfort afterwards doesn't necessarily mean it's come back. But there's a number of strategies for trying to sort out any menopause symptoms without bringing things back. One is just to wait for a while, because the longer you go without any HRT estrogen replacement after treatment for endometriosis, the more likely it is to fade away and disappear altogether.
Okay.
But there are other possibilities. There's the possibility of estrogen together with progesterone, and the trouble with that in the past has been that a lot of people are very intolerant of the synthetic kinds of progesterone we use. Now, we also these days have natural progesterone as well. I'm not saying everybody tolerates that all right, because they don't, but a lot of people who we would normally regard as progesterone or progestogen sensitive, that's to say usually they get sort of premenstrual syndrome-like symptoms when they take the progestogen, then quite a number of them find that they get on all right with natural progesterone. There's also something called tibolone or Livial, and that's something which is quite good at dealing with menopausal symptoms, because it works a bit like estrogen, but as far as the womb lining and the endometriosis is concerned, it doesn't work like that. So it's a potentially safe option. One of the things I suppose we have to say about HRT, because I'm going to have to say it at some point, is it can be a bit hit and miss. You know, we know where we start, but you know, certainly if you've run a specialist clinic like I do, you find a lot of people who've tried this, tried that, tried the other, and still haven't got it quite right. You can usually get it right in the end, but you know, it sometimes needs a bit of experimenting in terms of what suits one woman best. Now, the other issue that you raised there was the issue about the odour in the vulval area. Now, we may have time to talk a bit more about that in a minute, but just to address that particular point, basically, normally within the vagina, things are just on the acid side of neutral. And that's because you've got what people tend to call good bacteria, a sort of lactobacillus, same family as yogurt, but not quite the same organism. And that just keeps things slightly acid. That tends to keep all sorts of bugs, because, you know, although we think of catching infections, we have to remember that our bodies are also totally surrounded by various kinds of bugs. And they're kept out of the vagina by the acidity. And the acidity, the little lactobacillus, lives on something called glycogen that's in the walls of the vagina. When the estrogen goes, the glycogen goes, and you lose your natural acidity. So you can often get what we call colonization, i.e. taking over of the vagina by organisms that normally wouldn't cause any problem at all. I mean, the classical thing that we talk about is something called bacterial vaginosis, but actually that's specific to a few types of organism, and all sorts of organism can colonize the vagina. That's something that's worth mentioning to your doctor, because there are pessaries you can use which just replace the normal acidity and get the environment back to normal. The issue then would be whether you need to use a little bit of local estrogen to keep things back to normal. And we'll probably say it at some other point this evening, but there are very, very few people who can't take local estrogen. certainly we would regard that as being a safe option in somebody who's had endometriosis.
Thank you, Tony. So another question that we have here, the lady has said she had a hysterectomy, an oophorectomy for endometrial tumour and omentum cervix attached to ovary, stage 1, no mets. This was 8 years ago. She was told at the time not to have HRT. The patient states she has never had any support and is now worried about her cardiac health risk. She really wants respite from hot flushes, night sweats, and a whole heap of other symptoms, is what she said here. Right. So what would you suggest?
Okay, well, this probably needs a bit of help from either her GP or, better still, her gynaecologist. But the gynaecologist will have sent out a discharge summary when she went home from hospital, and that will probably give the sort of information we need. 90% of people with tumours, certainly stage 1 like that, are likely to be able to take some sort of hormone replacement. The issue is whether that should just be estrogen alone or estrogen plus progesterone. And most people would give both hormones, particularly if the surgery's been relatively recent. The issue of support's really upsetting, isn't it? The problem is that, you know, things have changed in our health service. And I remember when after doing a hysterectomy, I'd see somebody perhaps a month, 6 weeks later, as well as having seen them on the ward. And then maybe if they were still having problems, I'd see them another few times. Now there's a tremendous pressure to get everybody straight back to the GPs. And it's not that the GPs can't provide good support. It's just that they weren't there at the time of the operation and they don't always know all the details because they're not always told all the details. So it really can be a problem. I guess we'll talk about sources of support a bit later, but sources of support are important. I keep talking about GPs, but I'm sure you all know that these days, often the person who can help you best is actually the practice nurse rather than the GP. Not always, but often. And otherwise, it's just worth, particularly if you're new to a practice, but even if you've been with it for a while, just ask somebody, ask the receptionist who's the one that's interested in menopause problems, because there's usually one person that gets most of them, and they'll be the person most likely to be able to support you.
Thank you. Okay, so this lady had cancer of the uterus at 32 years old. She's now 60. She had no menopausal symptoms at the time. Other family members have had menopause between 50 and 60 years. She now has exhaustion, lack of concentration, reduced motivation, lack of libido, difficulty sleeping and joint stiffness. She's asked, could this be delayed menopause?
Yes, it's interesting, isn't it, that you would expect just logically that if you were going to get all those problems, you'd have got them pretty much straight after your treatment. It's not always clear why that doesn't always happen. But, you know, again, like the lady we were talking about before, you've got the cluster, you've got the range of symptoms that makes you think, yeah, this could be something to do with the hormones. The other possibility that's worth just thinking about, your ovaries make most of your body's estrogen. So when the ovaries aren't working, you lose most of your estrogen. You make a little bit in the fat cells of the body, but mainly you've lost it. Testosterone, which you also make in your ovaries, is a bit different because part of it comes from your ovaries and part of it comes from your adrenal glands on your kidneys. And whereas you get a really abrupt drop in estrogen at the menopause, it can be a more gradual thing with testosterone. Now, not everybody needs testosterone, but it can affect mood, energy levels, libido. So it's always worth just thinking about that. Having said that, testosterone works best on tissues when there's some estrogen around. Mm-hmm. So the issue would be to take advice on whether it's reasonable to try some estrogen. And then if that's still left some of those symptoms, particularly the libido and the energy, then it's worth thinking about a bit of testosterone as well. Not all general practices are happy with that. You might need to get to a clinic for it. Actually, this is a good point for me to just put in a little plug. I was going to put in a few plugs for the British Menopause Society because it's close to my heart. But we'll talk about their website later. But if you just Google British Menopause Society, there's two bits to it. There's the main British Menopause Society that tries to provide information for healthcare professionals, and there's the Women's Health Concern, which is more providing information for the public. But a lot of it's available. You don't have to belong. There's a lot of it's available on the front page of the website. And one thing that's available is a list of accredited menopause specialists around the country. So if you really don't know anywhere near you where you can find some help, it's worth going on to that. It's a fairly rapidly growing list, but the numbers aren't enormous, but you should be able to find someone not too far from you. So it might be worth doing.
That's a really good tip. That's a really good tip. Thank you. Okay, I think we've got two more questions for the surgical part, unless any others pop through. I've heard surgical menopause flushes can be more severe and go on for longer. Is this the same if ovaries are left intact?
Well, the first half is correct, that although it does vary a lot from one woman to another, if you look at groups of women, yes, they have more severe symptoms that go on for longer, just because it's more of a shock to the system and it takes longer to adjust to it, one would assume. But certainly that's well noted. No, if you've retained your ovaries, then we'd expect that to work out a little bit more like a natural menopause, even though it might happen early because of your surgery.
Okay. Thank you. Okay, and one that's come through as we have been talking. This lady says she is 2 years into surgical menopause due to endometrial cancer. Now, she has a family history of breast cancer, and she's been told that she cannot have HRT of any kind. She's been using sage tablets for hot flushes with little success. And she says her brain fog is awful, and she finishes it with help.
Right. Okay, well, that's something that really needs to be addressed at a specialist clinic, really. Some people who've had endometrial cancer probably shouldn't ever take estrogen replacement, but some could. The breast cancer issue, that we'll talk a bit more about that, but it often depends on other risk factors and other things in your history, as well as lifestyle things that we'll talk a bit about. So you just need somebody to give you a reasonably reliable estimate of what your level of risk is, and then you can decide whether that's a small enough risk that it's really worth it to get your quality of life back, or whether you think, oh no, I'll just stay away from it.
Thank you. Right. So we're on to some medical related questions now, and we have had some come through as you've been talking, Tony. So our first question is, patient age 44, vulval cancer, radiotherapy induced menopause. Prior to surgery, she was on the progesterone only pill, and she had no periods for a year after stopping. So she's asking, should I be on a continuous or sequential regime of HRT? And she goes on, it's probably a two-part question, which progesterone is better, micronized progesterone tablet or transdermal, and why?
Right, okay. Well, the first thing to say, I suppose, is to say that the progesterone-only pill can often result in stopping your periods, particularly the most popular one these days, which is usually called Cerazette or something like that. It commonly stops your periods. So that means that we've got two factors, really. One is we don't know whether the periods would have stopped if it hadn't been for the POP. Mm-hmm. And the other thing is we don't know, well, from that, we don't know where you are in the menopause process. Now, the story about sequential and continuous is, Well, if we go back a bit even before that, we used to just use estrogen alone for hormone replacement therapy and realized that wasn't safe for the womb lining, as well as the fact it gave people awful, irregular, heavy periods. So we added in some progesterone a bit each month. So this is a so-called sequential preparation where you're getting estrogen all the time, but adding in progesterone for about a couple of weeks each month.
Mm-hmm.
And the issue with that is that that gives you a regular bleed. It's reasonably safe for the womb lining, but it does give you a regular bleed, and people got fed up with that. So we then designed continuous combined, which gives you both hormones every day. And the idea is that because you're getting both hormones every day, you don't get the normal monthly thickening and shedding of the womb lining, and you don't get periods. The problem with it is that the nearer you are to your natural menopause, the more likely you are to get some prolonged irregular bleeding instead of settling straight into no periods. And for this lady with a POP, we don't know quite where she is in the process. I mean, the fact that she's not been bleeding with the POP suggests that the womb lining might actually be quite thin, which would be favourable for not bleeding on a continuous preparation. So maybe the answer is a continuous preparation.
Okay.
So then the next bits are, what about transdermal and what about which progesterone? So the convention is we call natural progesterone, and we call the others progestogens. And most HRT has progestogens in it, just because the practicalities of it from the point of view of the manufacturers are somewhat easier. So first of all, do you use transdermal or oral? Well, the first thing is to decide what you're going to do with your estrogen. Tablet estrogen slightly increases the risk of a clot in the circulation. So if you're at risk for that, tablets aren't a good idea. So tablets aren't a good idea for smokers or people who are well overweight, or definitely anybody who's previously had a clot in their circulation. So that tends to decide your route for your estrogen, and then you can decide what you do with your progesterone. Now, estrogen is reasonably easy to get through the skin, so you can have a patch you wear all the time, or a gel, or a spray that you spray onto the skin, and all those things get the estrogen into the system quite well. Getting progesterone in is not so easy. So you have a choice. You can either go for a synthetic form of progesterone, which you can get in a patch, and that will go through the skin. Or you say, okay, well, this is sufficiently important to me that I'm going to unpack it. I'm going to take the estrogen one way and the progesterone the other way. And in that case, you normally go for natural progesterone, which is a nightly capsule. There is a little bit of evidence to suggest that two kinds of progesterone, one is progesterone, and the other one is something they call dydrogesterone, which is the same molecule, but just given a slight structural tweak. And it may be that both of those are better, both from the point of view of clotting and from the point of view of breast cancer risk. So if you were to say what's the best progesterone, as far as we can see, it's either the natural one or the dydrogesterone, which you can only get in a tablet. So you can have a combined tablet with the dydrogesterone, or you can go for unpacking it and having your estrogen and progesterone separately. It all gets a bit complicated, I'm afraid, but those I think are the options.
That's lovely. Thank you for that, Tony. Okay, so another question we have is, if ovarian function returns, how would a woman know this if she is on HRT?
You won't. Basically, okay. is the bottom line. You won't unless, no, you just won't actually. So you have to make a decision at some point. And this is an important issue for women who seem to be going into the menopause horribly early, like in their 30s, for instance. The question is, how long do you hang on to see if things are going to come back? We usually say that after a couple of years of symptoms, you probably are not going to find your ovaries going back to normal. But we know that even with the very early menopause, perhaps 4% of women do actually go on to achieve a pregnancy. So it really has to be worked out individually, and it's art rather than science, really.
Absolutely, thank you. I'm just going to click on the questions because some of these relate. A lady has asked, I'm currently going through chemo and radiotherapy for vulval cancer, stage 3. I'm 49 and no sign of menopause. What can I expect re the menopause?
That's a really good question. It's a really good question for two reasons. One is about knowing the answer, and the other is that it just does highlight a terrible problem we've got in the health service, largely due to overload, that people aren't prepared in advance for these things. And when we wrote the NICE guidelines 5 years ago, we really tried to emphasize if you're doing something in terms of treatment for somebody that you know is likely to put them into the menopause and to give them symptoms, it would be really good if you either counseled them about it beforehand or at least signposted them, because there's lots of people around at the moment, like Victoria, for instance, who would be very helpful under those sort of situations. So the question of what can you expect? It does depend a little bit on the treatment, but probably the radiotherapy is going to cover most of the pelvis. And my guess would be that would probably stop the ovaries from working. I should say, incidentally, because this also applies to people who have a hysterectomy and keep their ovaries, sometimes ovaries just go into a bit of shock for a while and then they recover. So it's not unusual to find you get flushes and sweats, and then perhaps 2 or 3 months later, that's improving. It's just that really the ovaries have gone on strike in response to the kind of treatment they've had. Chemotherapy also tends to have an effect on ovaries, so the chance of starting to get menopausal symptoms is quite high. I mean, the good news is that with the kind of problem that you've had, that shouldn't normally be a contraindication to replacing your estrogen because it's not hormone dependent.
Yeah. Thank you for that, Tony. So, another question. The effects of radiotherapy, chemotherapy can be very similar to menopause symptoms, or obviously can induce menopause. How would a woman know the difference, or would she?
Well, sometimes you just need to ask, really. I mean, one of the things about people like me is that we've actually talked to rather a lot of people over the years, and like lots of healthcare professionals, we're reasonably good at pattern recognition. So if you say, I've just got one individual symptom, well, that might be menopause or it might not. But often, like some of the cases we've already been talking about this evening, when you get a cluster of symptoms, you think, oh, that must be menopausal. So that in general is the best way of telling. Again, same comments as we made before about blood tests, occasionally helpful, sometimes just non-contributory.
Okay, we've had another few questions come through, Tony, and it might be going back to the surgical side of things.
Yeah.
Some aren't. I'm 58, had a total hysterectomy with ovaries removed last year. I had various complications after, infections and hematoma. How long should the menopause last? I'm trying to do things naturally. How can I protect my heart and bones without HRT?
Okay, well, I'd be very rich if I knew the answer to the first question of how long will it last. It's really so variable from one person to another. If you take a group of women, large group of women getting, let's say, bad flushes and sweats, then about half of them are better 4 years later. And sadly, the other half aren't. And there's a small tail to this, so that there are a proportion of people who get symptoms later in life. So 65, probably 7% of women would still be getting flushes and sweats. So you're pretty unlucky if things go on for that long. In terms of what do you do to protect your health long term, really it's lifestyle. So that essentially means don't smoke, keep an eye on your weight, and obviously one of the problems of becoming menopausal is that the body does try and put on extra weight, tries to put it on your tummy because those cells can make a bit of estrogen, but that's not something that that anybody likes very much, but it's easier to stop it happening than to try and get rid of it once it's happened. Alcohol in sensible amounts. Exercise, really important. Exercise has a big influence, not just on things like your heart and your bones and your brain, but on your cancer risk as well. So exercise. Then diet, healthy, balanced diet. The big question is, and does it help if you add anything in particular to that? You know, like, should you have supplements of some sort or another? The evidence for most of the supplements isn't very good. I'm a fan of vitamin D because I think there is quite a place for that, probably for all of us, certainly all of us in this country. But there are other things which may provide some long-term benefits. But I would start off with all the lifestyle things. Oh, and it's probably worth, this lady said she was 58. So if you haven't had a general sort of MOT at your GP's practice, it's worth asking for one, really. You know, just to check the obvious things that you can't tell yourself, like what's my blood pressure? The other thing that probably people would pick up then at that stage is to see whether you've got any particular risk factors for getting brittle bones or any particular risk factors for getting heart disease, because that can be picked up on at that stage, and then it's worth having, you know, more measurements or more tests done.
Okay, thank you. I'm just going to check the Q&A because we do have some other questions before we move on to the other section. So someone has asked, you have touched on it before, but is estrogel, a big factor in returning endo post-hysterectomy? I have been told my endo, as in endometriosis, has come back post-hysterectomy and it is now deep infiltrating. Despite the surgeon telling me at the time all the endo had been removed, although my latest estrogen levels were very low. Thank you. Thank you for the question.
Yes, thank you. Yes, I was perhaps a little bit too optimistic when I said about surgeons being able to tell that all the endometriosis had been removed. Sometimes it can be a bit buried, and the trouble is that although it has a classical appearance when we look at it, some people have what we call atypical endometriosis, which means there are little patches there that you just really can't see with the naked eye. So it can be more difficult. The situation about the estrogel is, I would guess at this stage, if it's a question of needing to treat some more endometriosis, that it would be suggested that the estrogel be dropped or combined with a progesterone. But I think a lot of people would suggest dropping it at least for a few months while getting through treatment. So not an ideal situation to be in, but worth again getting some good advice on that.
Absolutely. Thank you, Tony. So if we now move on to the questions that we've had in with regards to breast cancer. So the first one, a breast cancer survivor on tamoxifen. She says, I don't understand how the tamoxifen is affecting my hormones. Right.
Well, tamoxifen is a kind of what we call a SERM. So I need to introduce you to a family of chemicals called SERMs. Stands for selective estrogen receptor modulators. But basically, all the members of that family are different. But what they have in common is that in some parts of the body, they think they're estrogen. And in other parts of the body, they think they're anti-estrogen. So tamoxifen is a good example of that. For instance, in your bones, it protects you against brittle bones. In your heart, it probably protects you against heart attack. In the womb lining, it also behaves like estrogen, and that's not so good, so you're more likely to get bleeding issues on tamoxifen. But in the breast, it blocks the estrogen. So it's something that can be used. I mean, a lot of people, of course, after they've had other treatment for breast cancer, will in fact have a low estrogen level anyway. But even if you have a high estrogen level, then tamoxifen will still work. So what it does to your hormones depends on where you're looking. And unfortunately, up in your brain, with the bit of your brain that controls your pituitary gland, we're beginning to realize now that things like flushes and sweats are actually controlled up there almost as much as they're controlled by a lack of estrogen. It's always been difficult to know, because if you've got low estrogen, you've got high activity in that bit of your brain, and vice versa. So it was always difficult to know what the culprit was. But one thing we do find with tamoxifen is that people actually get worse flushes and sweats than people who are in a natural menopause, and that's almost certainly because in that bit of the body it thinks it's an anti-estrogen.
Okay. Thank you. Okay, we have another question. We've got some really good questions this evening.
We have.
So this lady says she's frightened to go to a menopause clinic as her mum had stage 3 breast cancer. My hair is thinning badly. Brain fog makes it difficult for me to carry out my job. I cannot remember names, and taking minutes is impossible. Can you please advise regarding the risks?
Okay, so the obvious concern is the potential risk of hormone replacement therapy. So this has been studied for a long, long time. We've sort of got a consensus, but that isn't to stop the Daily Mail from having the odd headline that says the opposite. Broadly speaking, if you're in the group of women who only need estrogen, i.e. if they've had a hysterectomy, then that doesn't seem to make any significant difference to your breast cancer risk. So it looks as though the culprit is the progesterone acting with the estrogen. And we've said that maybe natural progesterone may be safer. But if we take HRT on average, including all the synthetic kinds of progesterone, then the answer is that over the course of time, you seem to get a small increase in breast cancer risk. That we believe, though there was a paper last year that didn't believe it, but in general, we believe that risk goes away within a few years of stopping. So it's slightly odd because, you know, obviously if you're an ex-smoker, you're at more risk for lung cancer for the rest of your life. But if you're an ex-HRT user, you're not at more risk of breast cancer. And that's quite important because as you get older, your baseline risk of breast cancer increases. And if hormone replacement is having an effect, it's having an effect on that baseline. So it's multiplying that baseline by a certain amount. So if you say what's the risk, well, what's the risk in your 40s is pretty negligible because people on HRT in their 40s are just taking it instead of what their body would have been making anyway. People in their 50s are probably taking a small level of risk, but it's pretty small. People in their 60s a bit more. So basically then it needs some assessment. There are some things that you can't do anything about that affect your risk. One obviously is your family history. One's what age you are when your periods start. The later they start, the better. One's how old you are when you have your first child. The earlier, the better. Breastfeeding protects. Non-smoking protects. Reasonable amounts of alcohol, low amounts of alcohol protect. And normal weight protects. So to give you some kind of idea of what we'd say generally, so this is for the women in general, not necessarily with a history of breast cancer, but not obviously at risk for other reasons, and taking standard HRT with a synthetic progesterone, which as we say may not be the absolute safest. So if you had 1,000 of them for 5 years, 1,000 women not on HRT in their 50s, for over 5 years, 23 of them will get breast cancer. If the same 1,000 women were taking HRT with progestogen in that time, then it would go up from 23 to 27. But to compare that a bit for you, those extra 4 cases compare with an extra 3 cases we'd have if all the women were smokers, or an extra 5 cases if they were drinking 2 units of alcohol or more a day. So that's 1 moderate glass of wine a day actually is 25% more risky than taking HRT in the same time. And then really the big thing is weight. The risks of, if you're overweight, And I guess everybody knows about body mass indexes, BMIs. You can always work out your own by Googling. You get a BMI calculator. If your level is 30 or over, normal range being 20 to 25, if your level's 30 or over, then that is 6 times riskier than being on HRT. And then lastly, if you take regular exercise for, say, 2.5 hours a week or more, then the number of cases you have so the number of cases that are prevented is twice the number of cases that HRT would have produced over that time. So I hope that gives you some kind of perspective, not saying it isn't a risk, but saying, yeah, but see it in the context of all the other risks which you take in your life, some of which you can choose and some of which you can't.
Absolutely. I love those statistics. I think they're brilliant. They're really good indicator. Right. We have another question. I'm a breast cancer survivor. I have few menopausal symptoms, but I can manage them.
Mm-hmm.
What would my risks be if the symptoms became unbearable and I wanted to consider HRTs? So I guess taking on board what Tony's already told us.
Yes, but the answer of what do you do when you've had a previous breast cancer is a really difficult one. And unfortunately, the science doesn't help. Some years ago, probably 10 years ago now, there was a randomized controlled trial being done in Europe to see whether, so some people were on dummy treatment, some people were on hormone replacement, they'd all had previous breast cancer. And it looked as though the HRT was slightly more dangerous, so they stopped the study. At the same time, there was another study going on in Stockholm with a slightly different design and slightly different group of women, but they stopped the study because they were scared because the first people stopped the study. Unfortunately, when they analysed their data, it actually suggested there was a benefit. But the problem was that because both of those studies were stopped early, neither of them are big enough to be confident of the results. So the bottom line is we really do not know. Mm-hmm. There are a few things to guide you, the things we've already talked about, but the other issues are your original breast cancer tumour. I guess you all know that we talk about receptors on tumours, which is just a way of saying whether or not they're capable of responding to hormones. Now, if you have a so-called triple negative one, so it's negative for estrogen receptors, negative for progesterone receptors, and negative for something else called a HERS receptor, then a lot of people, including a lot of breast specialists, would be happy for you to be on HRT if you had bad symptoms. The NICE guidelines, not ours on the menopause, but the ones that they've written about management of breast cancer, suggest that you should always keep an open mind on HRT because it's a quality of life issue. So while they say, do not offer it routinely, they do say, but if the symptoms are really awful, think about it again. And then the last thing is what I said before about natural progesterone maybe being safer. We just don't have the data on that, really.
Okay. All right. Thank you, Tony. Another question we've had come in as you've been nicely talking. Lady's 52 and finished chemo in June for breast cancer. She's now on tamoxifen, had no menopausal symptoms prior to this. Now she's having a hot flush, I nearly did a spoonerism then, a hot flush approximately every hour during the day and 2 to 3 night sweats each night. She's asking, is this excessive?
Well, if it was happening to me, I'd think it was excessive. Sounds awful. Yeah, I mean, that's miserable, isn't it? And the trouble is, it is probably, as you've sussed, related to the tamoxifen. There's 2 possible strategies, but you'd need some help from your breast specialist. One strategy is to say, well, look, we know that even in women with high levels of estrogen, tamoxifen still protects the breast. So one issue is, should we be talking about getting rid of the hot flushes with estrogen? The other thing is, would there be an advantage changing to what they call an aromatase inhibitor? Because that's a slightly different way of protecting the breast. it does give you low estrogen levels. You might still get some flushes and sweats, but in general, they tend to be less severe on that treatment than they would be on tamoxifen. Now, only your breast specialist is going to know whether either of those are sensible ideas to give consideration to, really, but definitely worth asking.
Thank you. Okay. So somebody has asked, will local estrogen reduce my symptoms?
Yes. In general, it really only works for local symptoms, but there's no denying that if you see a lot of people who've used local estrogen, particularly the creams, some people will say, and I noticed, without being asked, they'll say, and I noticed my hot flushes were getting better. And that's because, particularly with the cream, there is some absorption into the body generally. But no, in general, usually it's only going to help local symptoms. And by local symptoms, we're thinking of vaginal symptoms and bladder symptoms as well.
Absolutely. So we've got one question that has come through that I will just ask before we go on to that, because that other question was going to lead nicely. You mentioned age of childbirth. With what impact does not having any children, for example, having a full hysterectomy, and HRT risk?
Well, the not having children increases your risk, but if you've had a hysterectomy, then your HRT only normally needs to be estrogen, which is associated with no increase in risk. And so if we compared you with a twin sister who was still getting periods, then you would probably be safer than the twin sister, because the twin sister would still be giving herself estrogen and progesterone. You'd only be giving yourself estrogen. So need to know more detail, really, but a real possibility those things might just balance up.
Okay, thank you, Tony. So I'm mindful of the time. We're just going to sort of touch on genitourinary syndrome of menopause, because obviously this is something that, regardless of breast cancer, surgical or medical menopause, lots of women can endure. And it's known as a silent epidemic because a lot of women don't talk about it, they don't report it. So do you want to talk a little bit about that, Tony?
Sure, yes. As you say, lots of people don't talk about it, lots don't report it. Sadly, even when they report it, lots don't necessarily get the right treatment for it. So the starting point is, before you're born, the cells that will go on to line your vagina, and the cells that line the urethra that the urine comes out through, and then something we call the trigone of your bladder, which is a bit at the bottom of your bladder, which tells you when it's full and when you need to go to the loo. All of those are coming from the same set of cells. And the only way I can put it is they're greedier for estrogen than the rest of the body is. So first of all, what can they cause by way of symptoms? Well, in the waterworks, often cystitis, but if you go to the doctor and have a dipstick, there's no infection there. It's just that needing to go, not worth it when you get there, a bit uncomfortable when you empty the bladder, those sort of symptoms. Vaginally, it's quite complex. We've said you lose the normal acidity, you lose the normal lining of the thickness of the lining of the vagina, so it becomes thinner, becomes drier, becomes more uncomfortable. Lots of women will have very graphic descriptions of just how uncomfortable that becomes. It can be horrid. So all those things go on, but also there's a change in something we call collagen, which is a tissue which gives strength and elasticity to your tissues. And then if it's not there, tissues are more likely to sag. So prolapse-like symptoms become more common. And then there are other things like the way that the little individual nerve fibers work actually changes, and so you get a change in sensitivity not in a good way. So you get all those changes, plus often changes, you get changes in local blood flow as well. So you get changes in the lips around the vagina, the clitoris. So all those areas can all be affected by a lack of estrogen. And the two most important things to know about it are, it's not like the flushes and sweats which are going to go away one day. So it's a symptom of estrogen deficiency. It's not a, oh, never mind, my body will adjust to this sort of situation. The further you get beyond the menopause, the more likely you are to be troubled by it. So by the time you're in your mid-50s, if you had your menopause at 50, then within about 5 years of the menopause, not far short of half of all people are getting those sort of symptoms. There are things you can use which are non-hormonal, moisturizers, things like replens and so forth, but they're only really going to tackle the dryness. They're not going to tackle all those other symptoms. So there is a place for local estrogen, and you can get that in all sorts of different forms. You can get it as a little, what we call a vaginal tablet that you pop into the vagina. You can get it as a cream. You can get it as a gel. You can get it as a little ring which sits in the vagina and releases the estrogen. So there's all sorts of ways you can use it. But the other important message is what I said at the beginning. Those cells are greedier for estrogen. So for women who are actually on HRT, they often go along and they're told, you don't need it. You're on what we call systemic HRT. You know, your whole body's getting estrogen. Can't be anything to do with that. 20 to 25% of women on standard HRT still get vaginal and urinary symptoms. There are almost no contraindications, probably worth discussing with a specialist in the case of breast cancer, but otherwise no contraindications, no need to use progesterone with it, and no limits on how long you use it. Use it for as long as it helps. And don't think, oh, I've completed the course now, I feel much better, so I'll stop it, because it will, if you're prone to it, it will come back.
Yes. Thank you,
Sorry,
Tony.
that sounds a bit gloomy.
No, people need to be informed. That's why they're here. That's why they're asking these questions, which is fantastic. Thank you so much. So I'm just going to put a question out to our attendees. With regards to future webinars, if you could give some indication, perhaps in the chat, with regards to what future webinars topics you would like. For example, would you like to know about HRT and the alternatives, mental and emotional health in the menopause, bone and heart health, or menopause at work, or would you be interested in all of those topics? If you could pop that in the chat, that would be brilliant. Thank you. So Tony, I realised when I introduced you, I didn't explain what you do and what you are. We need to know this because we're very lucky, audience, with our guests this evening. Did you want to?
You probably sussed I'm a gynaecologist. I did a little training in psychological medicine at the beginning of my training, and then got involved in looking at psychological and emotional symptoms in the menopause, and that was 1975. So I've been running menopause clinics for 45 years now, and I'm still totally obsessed with the subject. I was lucky enough with some colleagues to be instrumental in, we started the British Menopause Society in 1989. And then, as I mentioned earlier, combined that with women's health concern. And yeah, I'm still really interested in menopausal problems.
That's brilliant. So people want to know about everything, basically, natural alternatives, mental and emotional health, bone and heart health. So yeah, thank you for that. So basically they'd like topics on all those sessions. Right, I'm just going to pop in the Q&A. I'm very mindful of time. So yeah, bone and heart health, bone health and alternative treatments for menopause, please, and thank you. And they've said, thanks so much, Tony.
Very welcome. I've really enjoyed it. Some brilliant questions.
There were some brilliant questions, weren't there? Thank you, everybody, for attending. It's most appreciated. And a big thank you to Tony for everything that you've done and for being so tolerant and generous with your time. So thank you, everybody. Bye-bye.
Bye.